Okay, so I've met a lot of you guys already, but so I'm Daniel Bender, and I'm actually born and raised in Memphis, Tennessee, and came up here to work in Jackson, Wyoming, but it was a dud of a job. It didn't work out, and I was working with these guys as needed. It's called PRN, and I just grew to really like them, and it coincided with with two of your longtime physicians retiring. And so it just seemed like it was a good opportunity. And that's why I'm here. I don't know anybody in Wyoming, and it's good to be in this group because all of you are warming and you've got a good head on your shoulders and you're trying to do good things. And I think that's what we all should be doing. And I think that's actually what we do there at Community Health Center. We're just trying to do good things the best we can, and we do that through medicine. So essentially, I just want to tell you a real quick backstory of what Community Health Center is. It's we have 4 centers in Wyoming. We have the biggest one is in Casper. It's a very nice building, and it's well staffed, and they offer a lot of different services. The other 3 buildings are not as beautiful as that. The one in Riverton is, I think, an old Sage West building, and that's what we are working in now. There's a clinic in Lander was a medical clinic, and now it's a pediatric clinic. We're not sure what it is yet, I don't think. It's all, everything's in flux. And then we have this great building in DuBois, and it serves as, I think, their main medical facility there. And just real quickly, Carl Harris is the first guy that I met who works at Community Health, and he is our CEO, and he's a really great guy, and I think he just gets it. He's not a doctor, but he just understands, I think, what we all need to work and maneuver. And then we just hired Dr. Brunson, who is our CMO, and listed there are the other administration. And then we have a lot of board members. You may notice some names up there.
I don't know anybody else.
That was advertising, wasn't it?
I didn't bring the program.
So, this is not meant to be like a feel-goody type of thing. Really, our mission is to provide affordable and high-quality care to the people of Wyoming who otherwise, would have to be going to the ER. These people, a lot of them are Medicaid and not on anything at all. They're just self-pay people. And I'll tell you a little bit about that. This is what we offer. We do not, we do accept all insurances, but I think this is the important part. We never refuse to see anybody because of their inability to pay, and I think that's a big deal. And the way we do that is in something that I haven't seen a lot of. We offer this sliding scale. Sliding scale is based on your income, your family size, and all that. And there's 4 sliding scales. And if you're of the most disadvantaged socioeconomically, you pay about $30 a visit, and your labs and and if anything you might need that we can do in that clinic is substantially reduced. We call it a nominal fee. And the other sliding scales are, a bit more expensive, but at least it offers access. And I want to bold this with my words, but I'm kind of monotone by nature. But we'll see if I can do it. This 340B program is huge, huge. We can get some of the best medicines known to man at a substantially reduced cost. We can take people off warfarin and put them on the new anticoagulants. We can get some of the best insulins. We can get some of the best diabetic drugs that are just coming out, and it is subsidized, and I think people have feelings about that one way or the other, but I think on the whole, these new medicines that we offer to people at a substantially reduced cost end up, I think, saving us all money because there's better outcomes, there's less hospitalizations, there's just lower social economic costs. That's my opinion. It's my opinion. But I was hesitant to put this in here, and disadvantaged here just means in the socio-economic realm of things. I just wanted to tell you that, I think if you just think to yourself, what do you think about Community Health Center of Central Wyoming? I asked a few people at this table, they didn't blatantly say it, but, they basically said that, yeah, I consider it as kind of for people who don't have insurance and all that. But I want to change that misconception just a little bit, because I just got a residency and I'm kind of doing some things that, that the probably not a lot of the doctors around here are doing, but I don't know because I haven't met a lot of the doctors. But essentially, I'm using this thing, it's called POCUS, it's point of care ultrasound. If you come in with a complaint, like a tendon injury, or a gallbladder problem, or a pneumonia, or you want to rule out a blood clot, we can just do it right there. And you don't have to spend days working up with the diagnosis, and you don't have to spend tons of money. I'll show you a little video. And including, I focus heavily on metabolic syndromes, obesity, and I do want to start a Suboxone program here.
What was that last word?
Suboxone. I'll show you. But this is, I want to, basically, if you were alive 150 years ago and somebody said there is a piece of medical technology that is going to revolutionize the way that all doctors practice, what would you think that they were talking about?
X-ray.
X-rays, a good choice. But that was around that time too, so it's not wrong.
Sterilization.
Well, that's a good one too. That's the biggest one. That's the biggest one.
I guess it's ultrasound.
It's not ultrasound. No, but there was a lot of people saying, "Oh, the stethoscope is unnecessary gadgetry." That the thing that you recognize doctors with, that the medical symbol, most of us associate with doctors, that stethoscope, and that when it first came out, people were like, "There's going to be variability in the way that physician interprets using that piece of equipment. It's not going to be standardized. It's not going to be easily, trackable." There was just a whole host of problems, but it's turned out to be the thing that doctors use the most. And the same thing is happening with the ultrasound. And let me show you. I wonder if
You give someone the power to
can you guys hear
inside
that?
the body. You give them the ability to diagnose things and see things that they never would
Can you guys hear that?
before. This is going to allow them to save a tremendous amount of lives.
Do you think we can turn?
IQ, we put powerful medical imaging capabilities in the hands of doctors all over the world.
Volume.
Exactly.
Someone the power to see inside the body.
Well, essentially, what they're saying, I know that's hard to hear, but this is a carry-around ultrasound machine. I mean,
This is going to allow them to save
it's the new stethoscope, and all the residencies are training their doctors to do it. And
When we launched the Butterfly
I can't impress upon you just how awesome it is to be able to use this. I wish we could all hear the video, but it's kind of like a fundamental shift in the way we're all practicing those. And so,
You have to have a giant machine attached to it.
I'll tell you, that if you're trying to rule out a cardiac problem, you're gonna want to get a very detailed echocardiogram. But if you're just in the clinic and you're like, oh, I'm short of breath, and the doctor's like, is it a heart problem, lung problem, or another problem? I don't know. Yeah, we don't know. It's been very difficult to say, but now it's way easier to say because you can look at the heart. Is it pumping adequately? Do you have fluid in your lungs? You know, all these clinical questions that would take days to figure out outpatient. Well, you can just, if you're a good interpreter, you can see it and you can just do it and you have the answers. And then the question is and then the question is what do you do about it? But so that's what I'm using right now. And I don't know if there are other doctors here that are using it in the way. I'm sure there are. Just 2 more slides. This is a brand new New England Journal of Medicine article. It's for people. This was a diabetic drug, and this article came out like a week ago, and it's saying that this was a almost nearly 2,000 person study, and the people that took this medicine are losing 15% of their body weight over a year's period. So I am offering like almost a weight loss type thing, but it's really more of a global health issue. And I don't really call people overweight. I don't say, oh, you look big. I just look at the BMI, and if that is in the red, as we say, I will offer you various things to try to cut down your risks of cardiovascular disease and diabetes. And this is one tool. There's many tools, but I thought this was really great because it's a very safe, effective medicine that's been used for diabetes for 2 to 3 years now, and they just know that's associated with weight loss. And this was the proof where you had on average 15% body weight loss.
Is it as effective as Fen-Phen?
It's that one actually was not that effective.
Really? Relative to this one?
It did make people lose weight, but it definitely when they stopped that drug, they all gained the weight back.
Huh.
And then it was associated with cardiovascular problems as well. So, but this is definitely not that. It's way safer. And then this is probably a controversial thing, but I don't know. I think I came up with that phrase. It's like using the vaccine. It's like having a vaccine and not using it. This is for opiate people, opiate addicted people. And the evidence is clear. I mean, you just look at all the journal articles. They're showing better quality of life for people who are addicted to opiates and using this medicine. And let me rewind here. So if you have somebody who is addicted to opiates and they want to get clean, they use this medicine that is an opiate like agonist and then an opiate blocker attached. It's 2 drugs mixed into one. And the thing about it is that it's a film and you use it subcutaneously, meaning under the tongue. If you try to use this drug in any other way, that opiate blocker overpowers the opiate. Are we understanding this? And it becomes a very safe and non-abusable medicine. And the people that are having these issues, that are stable on this medicine, they go, the people that you were saying, like what's the place that you just...
Eagles.
Yeah, I'm not saying that all people that are incarcerated have this problem, but some do. And it's a very similar story. I've seen a clarity of mind with people that are on this medicine and that go to work, that pay the taxes, that are contributing members of society, and they might be on an opiate, but at least they're functional now, and they're going to, I know many people who have, one patient I'm thinking about has a civil engineering degree. You would never know they were on this medicine. And
So does that mean that they don't have, while it is an opiate, they don't have any of the side effects, the drowsiness, you know?
there's side effects associated with it, but you know, the whole big picture is the risk versus benefit, you know. And it just turns out that it's just, there's data that's been collected over the years, and it just shows that these people just, on the whole, do a lot better with this medicine. And so the reason I'm bringing this up is that there's only 3 people in Fremont County that are doing this, and I talked with the CHCC admin people, and they're, you know, we're discussing all the details, but they do think it would be a decent idea. And I think it'd be good to add to this culture here in Riverton and Lander, just to at least be able to offer it to a few people. And I feel pretty strongly about it. And the thing here, you know, it's very difficult to quantify how bad your opiate problem is, but there's various secondary indicators. This is Fremont County up here. This is the amount of times that the EMS, the emergency people, had to administer the opiate blocker, naltrexone, to like save somebody's life over in 2017, and that was 286 people. So I just think it's good. You know, it's good. It would be good to add a 4th person.
So is there people in town that don't want you to be able to offer this? Is that the
You know what? There's a lot of misconceptions about it. I mean, a lot of people think that you're just you know, a lot of people say, oh, you're just giving my family member an opiate, and you're just going to make them into an opiate user again. But it's really not. That is technically true, but it's not true in the way that these people live out their lives.
And is it as addictive as opiates, or you don't get addicted?
It's apparently not as addictive, but addictive is relative. You know, the term addiction. It's just, I think people are dependent on it. I don't know if they're addicted per se. Yes, sir.
Can you explain the difference between an MD and a DO?
Yes, I would be happy to.
Quick.
Yeah, real quickly, the MD is a very, you know, historical term. And it comes from the old Greek and Europe societies and just all throughout history. The DO popped up in America in the 1850s, and it was a way to treat just very common sense things, very common things in a common sense way. So let's say you have a frozen shoulder. The MD is they're coming around, but essentially, can you improve the range of the motion with techniques that physical therapists do, that occupational therapists do, that, you know, this massage therapists do all the time, and I've been doing since the beginning of time, to improve people's lives. And I think the answer is, like with the restricted shoulder thing, yes, there are techniques that you can do instead of maybe, you know, maybe the traditional thing to do with that might be to stick a steroid in there with the needle. Why not try something a little bit more conservative first? And I think that's kind of where you know, there are many MDs that know this, and Harvard has a DO program, like you know, where they're training their physicians to be more conservative, I guess. But essentially, it's just a more conservative first approach to musculoskeletal type injuries. But on the whole, the MDs and the DOs, we all train together in residency. I train with many MDs, and they're my brothers, and I love them, and they love us. And I think, did I explain that okay?
It's more a holistic approach than.
I would, yeah.
Right?
Yeah, but you know, I mean, if you have like an acute kidney problem, the DO and the MD are going to be practicing very similarly. If you have a knee problem, the DO and the MD may not be practicing similarly at first.
this may be Josephine's job, but are we supposed to be looking for a beautiful Fremont County woman for you, or did you have your heart set? Did you have your heart set on a billionaire's daughter up there?
No comment.
I wouldn't answer that either.
With that, let's go back to the
Draw one chip.